Good afternoon. I am Mary Kay Bates, Community and Business Development Director with Scripps Mercy Physician Partners. Thank you for joining our partner webinar with Phreesia, The Year Ahead, Navigating the 2023 Financial Landscape. The pandemic propelled many changes for healthcare organizations, but few anticipated the massive challenges to the revenue cycle that are our reality today. Today, our speaker, Dr. Elizabeth Woodcock, will discuss the impact of these changes and share what you can do to safeguard your healthcare organization's bottom line in the year ahead. This webinar will be just under an hour, including a Q&A session at the end. And with that, I'll hand it off to Adam Rubenfire, a content manager at Phreesia, to quickly share some housekeeping notes.
Thanks, Mary Kay. We're excited to partner with Scripps Mercy Physician Partners for this fantastic webinar. You can submit questions at any time using the Q&A widget at the top left-hand corner of your screen, and I'll ask as many questions as time allows. In the resource widget on the left-hand side of your screen, you'll find a one-page overview of Phreesia, a blog post about how patients want to pay their medical bills, and an infographic about the cost to collect after the visit. If you have any technical difficulties, please click on the help widget. It has a question mark icon and it covers common issues. And since it's always one of the most frequently asked questions, this session is being recorded and we'll share a copy of the recorded presentation, copy of the slides by the end of the week. Finally, a few quick words about Phreesia. Phreesia is the nation's leader in patient intake. We're guided by our overarching mission of creating a better, more engaging experience for patients, providers, and staff. Our innovative platform enables our clients to improve efficiency, enhance clinical care, and give patients the convenient, flexible experience they prefer. We're proud to have been named the top-ranked patient intake solution by KLAS for 4 years in a row. To learn more, visit phreesia.com. And if you're interested in learning more about Phreesia, you can request that consultation using that drop-down or visit phreesia.com. But I want to go ahead and introduce our speaker, Dr. Elizabeth Woodcock. And Dr. Woodcock is the founder and principal of Woodcock & Associates, and we're so excited to have her with us today. She's widely considered an industry leader in practice management, having focused on medical practice operations and revenue cycle management for more than 30 years. She's the author of 18 books to include the physician billing process, Potholes on the Road to Getting Paid. Elizabeth is a fellow in the American College of Medical Practice Executives, and she's a certified professional coder. In addition to a BA from Duke, she holds an MBA from Wharton and a doctorate in public health from Johns Hopkins. And with that, I'll turn it over to Dr. Elizabeth Woodcock. Elizabeth, the floor is yours.
Thank you so much, Adam, and thank you to Phreesia for sponsoring today's webinar. Most of all, thanks to all of y'all for joining me to hear about what may not be the best news, but will improve your knowledge. The year ahead in 2023, navigating that financial landscape for your healthcare organization. One of these years, I hope to actually start the year off thinking all of the joy, the excitement, the lack of complexity for the reimbursement landscape for the year ahead. But once again, we're in for quite a ride. So what are we going to be talking about today? I'll bring the perspective about an important issue in the financial landscape, and that is telemedicine. I say important, it's something that we've turned a lot of our services over to, but it's also important because of the external environment and seeing a lot more telemedicine even outside of what I like to refer to as the legacy healthcare system. That is hospitals, health systems, medical practices, and probably those of you represented on this call. So what's going on with telemedicine? Then we'll take a deep dive into Medicare reimbursement because, of course, as luck would have it, policies have changed literally over the last few weeks with regard to Medicare reimbursements. We want to understand what's going on with that. And then that pesky little sequestration. We've seen that in our environment for almost the past decade, that pesky little 2% reduction. And we don't have a lot of margins as it is, so it's really frustrating. So will we continue to see that? Then we'll briefly touch on the No Surprises Act. This was a big change from a revenue cycle management perspective. So we'll kind of get a little update on where we are with that. The quality payment program, for those of you who do actually have to participate in this voluntary program of the government, and I use air quotes around that, because if you decide not to participate, there's a 9% penalty. 9% penalty on your Medicare reimbursement. Then we'll touch on CPT 2023, and we'll kind of gather this policy information that we've had to date and delve into some non-financial trends that are affecting us on the revenue cycle management side. That, of course, is the Great Resignation of our team members, of our staff, and then wrestling with this continued rise in patient cost sharing. We'll go with a brief conclusion and then delve into our Q&A session. Now, because as you can hear, we're going to be talking a lot about policies in the US today. One of the things that I love to do is not just listen to people like me, or, I read a lot online from consultants and law firms about what's going on from a reimbursement perspective, but I want you to be able to go to the original source. As you heard, I have a very academic background and I like to go right to the original source. I don't want to hear any filters. So one of the things that I hope this webinar will help you with is I've curated those original sources for you. They're going to be, as you can see on the top right hand or the right hand of your screen, in that little go-to arrow, and you'll see those resources listed. Once you click through those are going to take you to the specific documents that are creating the topics about which we are discussing today. The first is the public health emergency. Now, the first public health emergency came actually before any of us knew about the pandemic in January of 2020, as you can see here. So we've seen this renewed every 90 days since Q1 of 2020. And this quarter is no exception. We do know that the public health emergency will extend into April. And part of that is because, and this is something that is important for us to even realize, is the government has pledged to give a 60-day notice as to when the public health emergency will end. As to when the public health emergency will end. And you may say, well, who cares? I know that public health emergency doesn't really matter. But what it is doing is it is actually creating an environment where, in essence, it's putting laws on hold. So you could kind of think of it as like, the rules of the road, like the speed limits. If we could come in and the Department of Transportation could basically say, we have an emergency. So when you're on this highway, you don't have to go as the sign is posted at 65 miles an hour. We're going to give you an exception for this period of time. And that's exactly what the PHE is allowing us to do from a healthcare perspective in certain arenas. And one of those most important arenas is telemedicine. And so what we see here is, I think this is a great source in terms of your healthcare organization to understand what services are being paid through telemedicine. And that also includes the exception for audio only. Basically, I just have to have a phone call. I don't even need a video component. And I've just given you one screenshot of the 262 CPT codes that we see that flexibility being enabled. We see the ability then for healthcare organizations to go ahead and freely use these CPT codes in the environment of telemedicine. And again, you may be asking why. Well, what's fascinating is from the late 1980s, the government did go ahead and allow for telemedicine reimbursement through the federal insurance program that we call Medicare, but it was only in specific instances. And that included the fact that the patient could not be at their home. The patient, in fact, had to be at, in essence, sort of a facility like a critical access hospital. They could have been at a facility where, as we know, in the 1980s and 1990s and 2000s, pretty fancy equipment. It was a very, very small amount of billing for telemedicine. It really just was honestly a non-entity. The reason it was a non-entity is because of these restrictions, again, that are now being relaxed, much like we would the rules of the road. They're being relaxed by the public health emergency. But there's a lot of chatter in the background that I wanted you to be aware of. And the chatter in the background, here's a great example from MedPAC, which is the Medicare Payment Advisory Commission. It is, if you will, the advisors about healthcare to Congress. And I always like to read their information. Again, it's MedPAC, because it gives me a sense of what is being fed to members of Congress about the national healthcare agenda. And you can see supporting safety net clinicians. We've got this post-acute prospective payment system, not surprisingly, staffing at nursing facility. And then look at the last agenda item in this public September 2022 meeting, the expansion of telemedicine. And in that report, it talks about some of the real benefits of telemedicine. We've got access to care. Yay. We've got the promotion of equity, partially because it doesn't require transportation from the patient's home into a healthcare facility, many of which are in urban markets. So we've got that promotion of equity if done well. It's cost effective, it's safe and efficient, and the government argues an effective delivery platform. On the flip side, the government is very attuned to the issue of overuse, overpayments, and the potential for quality and poor care. And I think we might, I mean, certainly as a lay person, I agree with sort of this debate between the benefits, the pros, if you will, and the cons. Now, what's also interesting, just to be aware, and this is something I certainly wasn't aware of even months ago, is why wouldn't we just keep this public health emergency to allow us to continue to use telemedicine on an, if you will, as needed basis for, a long time to come? It's just kind of like a public health emergency. Yes, it's a public health emergency. Well, the issue comes down to the more important issue, if you will, from the government's perspective, has to do with Medicaid. So the public health emergency is, in essence, kind of allowing Medicaid expansion to occur at the state level. And Congress does not, or many members of Congress do not like that. And so we're seeing a lot of pushback to the public health emergency because of Medicaid expansion and the ripple effect, of course, for us in healthcare organization is telemedicine. So it's created, what is really a pressure cooker associated with what's going on with healthcare, particularly in light of some of the challenges that we're seeing in terms of the lack of bipartisanship in Congress. So what happened? Before the end of the year, the government stepped in. As you can see, it was signed into law on December 29th, and agreed to the Consolidated Appropriations Act of 2023. This is a massive 2,000-page document. But if you're interested in what is relevant for us in legacy healthcare organizations, as I pointed out below, you want to start on page 1439, and you'll start to see some of the changes that we have that are relevant specifically to us in healthcare organizations. This does include those waivers associated with telemedicine. Patients can be at home, and we can see patients over audio-only services and bill and receive payment for those remarkably through December 31st, 2024. So I think this is good for those of you who have put a lot of your heart and soul into telemedicine and then just kind of been really fearful at this end of the 90 days. Is this PHE going to be extended? Is it not? We put a lot of resources in here. So now we know the Consolidated Appropriations Act of 2023, it is the law. It is allowing telemedicine through these flexibilities to extend through the end of next year. So we've got about a 24-month runway to allow the government to do a little bit more studying on this. And it's not going to be a surprise that the government does. And I say that because The legacy healthcare organizations, you and your hospital, your health system, your medical practice, yes, we've embraced telemedicine, but it's still at a pretty low level. Where we're seeing the massive changes actually has to do with the money that is being poured into the non-legacy systems, the Amazons of the world. Of course, we're seeing a lot of movement with both publicly traded companies as well as private, some early stage, some mid-stage companies. They're really making massive changes to the healthcare ecosystem. And honestly, the genie's been let out of the bottle. I say that because patients are expecting this. If we go at the end of 2024 and say we're not doing telemedicine anymore, we're going to get some significant pushback in terms of legacy healthcare systems. So I think there's like a double-edged sword for us from a reimbursement perspective. We're super excited to be able to continue to perform telemedicine and be paid for that in this nice runway of about a 24-month period. But we also have to recognize that that runway has been given to our non-legacy system partners. So that is the, Amazons of the world, the Walmarts, the Walgreens, and all of those early stage companies or mid-stage companies that now also have that same runway, and they're developing and of course putting a lot of lean into telemedicine in the market. Now, the nice part is that we know for this 24-month runway that the patient can be located in their home. That's a really big exception, but there's a lot of other things at play. In fact, provider licensure. So can providers work over state lines? What's going to be the payment relationship with Medicaid? Are we going to be allowed to continue to see new patients, or is this going to be an issue for established patients only? So the key here is that the states are also involved. If you're interested in kind of following really the state-based opportunities, you may want to take a look at the website that I provided here at the bottom of the page to really understand where the future is. But honestly, there's still, despite this extension from the Consolidated Appropriations Act, there's still a lot of unknowns about telemedicine. But one of the things that we do know is that Americans are demanding it. So as legacy healthcare systems, I think we're going to have to figure out how to do this right in order to retain and meet our patients' expectations. It's going to be Medicare reimbursement for the coming year for professional fee services. And indeed, the reimbursement is the unit, the RBRVS, a relative value unit, times a conversion factor with a few tweaks for geography, and that gives us our reimbursement rate. And as you can see, what we did was a Medicare conversion factor was declined by 4.48%. This was certainly not very welcome news that we received the first week of November. Why, indeed, after such a challenging year, would physicians and advanced practice providers see this incredible decline in reimbursement? Well, the government explained it very, very well. We saw a 2022 conversion factor of $34 and some cents. And then last December, we'd had the government come in and kind of up that to $33 and about 60 cents. But the government said, hey, listen, we can't just go by what y'all did in the last month of the year. We've got to go back to the law, the overarching law, and create that budget neutrality, which is basically a fancy word for we can't spend any more money than we have. And so we're going back to the neutrality adjustment, and we're spinning out this $33 and some cents. Honestly, it's because we had kind of a stay in that execution last year, and we pushed that forward. And then, of course, the government said, listen, we've got to rejigger this, and we're seeing a 4.5% decline. Now, As I mentioned, this Medicare scale, the resource-based relative value scale, that actually is tied to all different CPT codes, and there's almost 10,000 of them. And based on the CPT codes that a specialty uses, you're going to see a little bit of increase or a little bit of decrease because these units themselves change. So as you can see from the slide, diagnostic testing facilities got a bump up, as did ID. I guess kind of not surprising. They've been really the leaders in the COVID pandemic response. And then our hospitalists in particular, as well as office-based physicians for internists. And we saw a decrease for IR and vascular surgery because they used a same bundle of codes that were affected, that were basically softened, the reimbursement, the units were softened. Now, what's the other interesting play with this year's 2023 Medicare fee schedule is you can see from this chart, and I just took one screenshot, but I've given you the source there, is we've seen a difference in facility and non-facility reimbursement. So let me draw your eye, for example, to infectious disease. I mentioned that overall we're seeing an increase for ID, but for non-facility providers, that's a decrease of 2%, while for facility providers, it's 6%. And you may say, oh, cut to the chase here. What does this word facility mean? Well, facility means a hospital-based clinic. A clinic, a provider that is based in a facility is a hospital-based, or sometimes we call them a provider-based clinic. And so I point this out because I think it's unfair to just say overall, we're seeing increases for some of these specialties, when the reality is that most of the boosts have been in the facility-based settings, which is unfortunate for those of you who are in private practices, because as you can see, you're not seeing as much of the increases. So again, a non-facility is a place of service 11, while a facility is either off campus, which is place of service 19, or on campus, place of service 22. Reimbursement. But wait, because there's always more. And you may say, well, Elizabeth, I didn't hear about this 4.5% decrease. Well, the reason you didn't is because in the very, very last hours of 2022, that same law, the Consolidated Appropriations Act of 2023, which gave us the telemedicine extension, also really softened that blow that we were going to see for Medicare reimbursement from 4.5% to, as you can see here in the text, to 2.5%. So the new conversion factor, the final conversion factor that the government put into play for 2023 is, well, I don't want to say just a decrease of 2.5%, but it is a decrease of 2.5%. And I guess it's better than 4.5%. I certainly would have liked to have seen an increase, but we are living with this final conversion factor of $33.89. For you to find out what that means for your healthcare organization, the Centers for Medicare and Medicaid Services have already loaded this revised, even the December 29th decision, the revised rates. And I've given you here this go-to resource, super easy to look up at the CPT code level. You can even get the reimbursement for your local geographically appropriate reimbursement as well. Now, speaking of reimbursement and telemedicine, we've talked about these two issues thus far. I did want to make sure that you are aware of this great educational tool that CMS has put out. And you can see these are Medicare preventive services. And if you click on any one of these tiles, you will actually be able to go to all of the rules associated with payment for everything from alcohol counseling to annual wellness visit to IPPE, which is the initial preventive physical exam. And you can see right here how many of these services are payable over a telemedicine platform. And again, because we just mentioned, you now have that 24-month runway. If you had hesitated putting together a telemedicine service for your own organization, I think it's fair to say that your investment of time will pay off now that you have this 2-year runway to go ahead and be able to bill and get paid for those services. So I want to make sure that I made a note of that, not only of the preventive services and this great tool, but also it shows you what is eligible via telehealth. Now, I mentioned very briefly in the opening that pesky little sequestration. During COVID, we had a little bit of a break from sequestration. Unfortunately, it was supposed to end next year, but because we took a break from it, the government actually pushed it through to 2023. Because it's interesting, just talking about policies, every time we see a decrease in the reimbursement decrease that we were supposed to get, or we see a change in sequestration, for example, we say, oh, well, hallelujah, it's only 0% now. It's not that it goes away. It just gets pushed down the road. And unfortunately, it's catching up with us now. We do now have sequestration back in 2023. And we will see that in our environment, or better put, on our remittances through 2030. Now, as you are all keenly aware, we had to comply with the No Surprises Act as of January 1st, 2022. But I think the government didn't realize how overwhelmed they would be with all of the information and attestation from providers with regard to the No Surprises Act. And that's really where we're sitting today, which is honestly just a complete dearth of disputes that have been initiated by healthcare organizations. They've been an incredible amount of disputes that haven't been processed. And so there's a lot of organizations and there's a lot of patients, to be honest, that are kind of held in this limbo. Now, organizations are now reporting that these disputes are being processed, which is great news, but there's a ton of backlog. In fact, I know of practices that literally have thousands of disputes that are sitting in queues. So I think we'll see, hopefully, a better 2023 as the government kind of gets its act in order. And they've hired a lot of third parties to help them through these independent dispute resolutions. But I would say if you have some of these disputes in play, they're sitting in work queues, is to continue to be patient as the government works out its own compliance with the No Surprises Act in 2023. Now, I did want to mention the government's quality payment program. This is relevant to Medicare reimbursement. As I mentioned in my opening, it is one of those kind of almost voluntold programs, and that if you do qualify for the program, which means you have to have, I don't want to say a fairly high, but 90,000 in Medicare Part B charges per eligible provider per year. So, you do have to have a fair amount of Medicare volume in order to be voluntold. But if you do qualify for the program and you decide not to participate or not to participate successfully, you are staring in the face of a 9% penalty, which is a pretty high stakes game. And so right now, in the first couple of weeks of January, we're kind of sitting in this little bit of an odd place because we're reporting on last year, which is the 2022 performance year, and yet you still actually have to be reporting on this coming year, which is the 2023 performance year. Now, where have we been in terms of quality payments for the quality payment program? The most recent data that's available is for the 2020 reporting year. And let me pause here and say that that's one of the frustrating things about this program, which is basically we're getting reports from 2 years ago, now 2.5 years ago for the 2020 reporting year. And I think even more depressing, I would argue, is that those great healthcare organizations that have jumped through a ton of hoops with this program, and they've gotten 100 points. And And if you participate in the QPP, there's a lot of hoops you have to jump through, and you've done a great job at it. And you've gotten those 100 points. You've scored at a perfect score. And for that, you've been rewarded. In 2022, your remittances were 1.87% higher than your colleagues. And that's because, again, there's a 2-year runway in terms of the performance year to the actual year where you get a boost or that penalty of 9% if you failed to participate. Now, the bad news is that even those little tiny, and I could read you the list of the years before, but it was 1.6, 1.7%, 1.8%. So we've never even gotten to 2% in terms of a bonus for great performance. Is that even those little bonuses for exceptional performance, 2022 was the final year to be able to even garner those. So starting in the year we are in now, 2023 performance year, even a perfect score is probably going to get you a few cents on the dollar. And the reason behind that is when the government did form this program, basically Congress set aside a multi-$100 million pot of money and said, y'all can use this for the first 5 years of the program to reward providers who are scoring well, who are scoring exceptionally. And unfortunately, those 5 years are over. So I think 2023, when you look at the year ahead, you kind of have to ask yourself, what's the business case for the quality payment program? What does trying to get a perfect score really, what does that take? Because you're not going to garner any sort of reward for getting that perfect score in 2025, which is the 2-year increase that you would be looking for 2 years down the road for your current year today. So you may be a little bit frustrated by that news, and I apologize. You may want to look into what are called the exception applications, which is basically, hey, I have to participate in this program. I don't want to see that downside of 9%. That's a really hefty penalty. And so what do I want to do? What do I do if I don't feel like I even want to report for the QPP? Well, you can certainly take a look at the exception applications. I did want to make mention of the January 3rd, 2023 deadline for the exception application for last year's performance, the 2022 performance. That has been extended until March 3rd. And it has been clarified that you can accept yourself, you can basically get out of the program for COVID-related disruptions. And I'm not sure who hasn't had a COVID-related disruption. The nice part is you don't have to prove it. You basically say, I have COVID-related disruptions, and you can go ahead and apply for exemption, and you won't be able to gain anything. You won't get any sort of increase, but I'm not sure there was much on the table for you anyway. And what it does is it allows you to avoid that 9% penalty on the back end. If you do want to participate in 2023, we could spend hours talking about all of these different rules, but I just wanted to give you a high level. There's a 75-point threshold. There's the same weighting of the categories. Quality is 30%, promoting interoperability is 25%, et cetera. There are changes to the quality measures. And one of the ones that is most used is the pneumococcal vaccine. That actually has been changed. So before you get too far in your performance year of 2023, be sure to run through those changes on the Quality Payment Program's website. And maybe think about that 2022 exception application for COVID-related disruptions that was just recently announced. You've got until March 3rd at 8 p.m. Eastern Time in order to apply. Now, we didn't see a ton of changes to CPT code with the exception of one, and that is if you perform services in the hospital associated with observation care or inpatient care, you definitely want to take a look at the changes. I always love to buy, it's less than $100. The CPT changes 2023 that you can see on your screen is available from the American Medical Association. And the reason I like it is they are the horse's mouth for the CPT codes, because they're the ones who author the CPT codes. And so if you have a significant amount of changes, I always think that's a great resource because it really goes over in intimate detail those changes. Definitely well worth the investment of $100 or so in order to see those if you have a big change in your specialty. So as you can see, observations merge with inpatient codes. We'll go over those in just a minute. We have new cognitive behavioral therapy monitoring, or CBT. And again, another inpatient observation prolonged services code. And I think it's really interesting. This is the second year in a row that we've seen a new appendix for healthcare technology related codes. This one is for AI applications. And why does that matter? Because once we get an appendix, then it moves into becoming a real CPT code, which generally takes somewhere between 1 and 4 years. So now we have a whole section on AI. I mentioned those hospital codes. We saw in 2022 some major changes for the evaluation management codes for office-based services. Now we are seeing those same changes being brought into the hospital and observation, which are now basically collapsed. We're seeing those changes being brought into our inpatient realm. Definitely, if you're a hospitalist practice, if you are still doing consults in the hospital, your services, pulmonary, et cetera, you really want to make sure that you get really acquainted with these changes that started with dates of service, January 1st, 2023. Now, we know that it's not just regulations and changes to the CPT codes that make differences in the reimbursement landscape. A lot of stuff going on in our environment. We've heard about the Great Resignation for now almost 2 years, but it's mostly been for providers, for clinicians, for nurses. But what I'm seeing is there's a lot of impact now on the revenue cycle because those auxiliary positions are also being affected, not just at our receptionist positions, our schedulers, and of course, those great business office team members. In the past, we were already up to a 30% turnover. That was the industry data, 30% turnover. We've only seen that increase for administrative positions. Speaking of trends, another thing that we've seen in the last 3 to 5 years is a massive increase in cost sharing. There's no more of these cute $10 co-payments that we used to have in really for all specialties, but particularly in primary care. The average co-payment has shot through the roof. It's $27 in primary care, $44 in specialty care. And what's interesting is when you go back and you look at a 99212 in terms of reimbursement, it's darn pretty close to $50, $60, which means you're actually getting 100% of the allowable from the patient's financial responsibility, not from the insurance company. And that's really been a game changer in the last few years as we've seen this massive rise in cost share. And it's been significant. You can see this data point from Forbes Healthcare that was just published in 2022. Despite below average healthcare inflation, employees paid a shocking 10+% more in out-of-pocket healthcare expenses than the year before. And we don't see any idea about that trend changing. And I think somewhat has to do with really thinking about confusion on consumers' part, and that during the COVID pandemic, Very quickly, as you can see, in March of 2020, there was the Family's First Coronavirus Response Act that was passed into law that basically said, hey, listen, you have no financial responsibility. You have a full cost share waiver. And in fact, not only did the government do this, but all private insurance companies. You can see I've just given you Cigna's policy. The government allowed us to waive all cost shares for COVID-related care for a pretty significant amount of time. It was about 18 months for most insurance companies. And I do think that is causing lingering confusion on our patients' part. And it's one of these areas that I would actually consider engaging with my staff to explain what happened so that they can have a great narrative when patients are themselves confused. So indeed, that rise in cost share, what do we do in our own practice to really at least, if not solve for it, at least combat it? I think the first thing is to really think about our cost sharing, that rise in patient financial responsibility as a patient experience issue. And I say that because there is really no better opportunity to increase, to really put our eggs in the basket of improving the experience of patients than thinking about how to address this challenge of cost sharing. And the reason I say that is because patients can have a service, they can be super, super happy with it, and they get a surprise bill 6 months from now, and it's all gone. All of those expectations, that service we thought we had done, that loyal patient we thought we had created, is all gone. So I like to see a merger of patient experience, thinking about that in-office experience where hopefully we operate a really great practice and we don't have signs like this where we're making our patients wait. We're really thinking about really kind of meeting our patients from a convenience perspective, because what that means, the optics we are creating is they will pay their bills. And so if you haven't done this already, again, engage with your CXO, engage with your director of patient experience on this rise in cost share and really talk about how we can set expectations. This could be like, what do you have on your website? What materials do you present? I say materials. This could be electronic or paper. Do you present to patients? When you talk about, for example, in compliance with the No Surprises Act, and you talk about the cost of care, what is your scripting? How do you actually present it to patients? So that expectation setting really sets the narrative. And I think this is so important. And I'm going to go back to what we talked about at the very beginning, which is this whole telemedicine thing. And again, as legacy healthcare organizations, we may or may not embrace telemedicine, but what we're doing is we're creating an opening for all of these new players in healthcare to be able to come into our industry, come in to share this field, to be able to provide services to patients. And they're doing a much better job in terms of pricing. Now, we can talk all day long about why it's difficult for us to do it. But if we don't get this right, we're going to have patients who call us for an appointment and we kind of bumble that. And you know what? They're going to walk right across the street to Dollar General and get their kids' care or their own care, right? And the interesting thing is, as legacy healthcare providers, we're never going to know it. We're never going to know it until it's too late. So expectation setting, I think, is really important. And really think of yourself now as competing with the best of the best in retail. Because folks, we're competing with Best Buy Health. We're competing with Walgreens. We're competing with all of these early stage companies that are really, really honing in on this expectation. Then we need to make sure on a pre-visit basis that we're really doing a darn good job of not just scheduling patients at a date and time that's convenient for them, but also engaging in their, I don't like to call it financial counseling. Blah, what a horrible term. In financial advocacy, so that we're really reinventing how we address cost sharing from a healthcare system by thinking about it as an advocacy lens. It's a totally different narrative than to really work with our teams, train our teams, think about scripting. We think of ourselves as advocates rather than counselors or, oh my goodness, billers. Not a good idea. So at the visit, we want to make sure, of course, that's seamless. We've got to get our patient to the back. So how can we do as much as possible before the patient is even enters our hallways to try to reduce their weight, be convenient, get them to the back, and do a great job at it. And then, of course, thinking about post-visit. And there's a zillion ideas that we can think of, and most of them are pretty simple, like why we send statements. I don't care if you're sending them electronically, which you should be, or paper. Why do we send them once a month? I don't know. That's the way we've always done it. And I'm asking that in the context of, when do we as Americans get paid? We get paid twice a month. Okay. Well, why don't we actually think about then asking our patients for payments twice a month? Oh my God, never thought of it that way. So bring in different voices, bring in your team members from experience, and think about how we can do this better from technology experience, and really start to recognize that this isn't just a revenue cycle, a business office issue. This is all of our, not just jobs, but duties. It's all of our responsibility to be our patients' advocates. Now, the good news is, well, I think it's good news, is that we are seeing a pretty significant amount of surge in demand across the board, across all specialties. There's some specialties are really taking in the chin, but most specialties are seeing that increase. Not a surprise, right? Because we saw a decrease in 2020. But I think what that means, this is my prediction, and maybe we'll leave it on a good note for our webinar for the reimbursement in the year ahead, is that because we are seeing the surge in demand, that we will continue to climb up in terms of priority when it comes to working with our health insurance companies. Because I feel like we've really gotten into a bad spot. We've kind of been price takers. We really haven't had any leg at the negotiating table. And now that there is so much demand, I want you to know that you're in the driver's seat and to try to continue to push back in 2023 against this softening reimbursement, because I do see those tables turning in 2023, and hopefully in 2024, we'll get some even better news when it comes to reimbursement. Now, while I haven't been able to give you all good news from your time today, I do know that knowledge is power, and I hope that I've been able to do that at the very least. Adam, looking forward to our questions.
Dr. Woodcock, thank you so much for such a great presentation. Thrilled to share some of the questions we have. We just got a little bit of time. So audience, if we don't get to your questions today, please send them through. We'll liaise with Dr. Woodcock and make sure we answer some great questions for you. So I want to start, we're at the start of the year of 2023. It's a new year, and we've got a deductible reset. How does that impact a practice? Like, what should practices be doing differently at this time of year compared to the fall? That's a question we've got.
Well, especially combined with the great resignation, we know that you probably also have new team members. So I think it's a great time to really be able to sit down and, I think at the very basics, really teach our team what is a deductible. And I know that sounds really silly, but all of us are kind of in this world of revenue cycle management, co-insurance, co-payments, blah, blah, blah. But like, take the time to actually sit back and say, what this means is that the patient pays first. So when we talk about reimbursement and United and Cigna and Aetna, what we actually mean with a deductible reset is we've got to chase down that money from the beneficiary, from the guarantor, from the patient. And so we've got to really think about our scripts, think about how we talk to patients, how we set expectations, and realize that there is a really big opportunity to change just the way we talk, looking our patients in the eyes, having our signs, for example, instead of saying, we expect you to pay your copayment, well, that's actually not really correct. Your insurance company expects us to collect your copayment. So it's the small things. Talk to your team. I think staff training is a really important opportunity at this time of the year, Adam.
Excellent. Dr. Woodcock, one more question before we go. You talked about claim denials, and some of that can come from, from coding, it can come from information about the patient. Is there anything we can do in the intake process? Do you have any advice on how changes to intake and registration can help avoid claim denials down the road?
Accuracy, accuracy, accuracy. We know from all research associated with claim denials that registration related denials are the number one reason for
Wow.
denials. Now, that is a very large category. I don't want to throw all the, healthcare organizations under the bus and say you do this bad, because it's a very large category. And some of it may be that the health insurance company hasn't updated their databases for the correct beneficiaries, et cetera. But really making sure we know how important registration is, and checking that insurance eligibility right up front. And then even more importantly, because I think our healthcare organizations do a great job of that, but when it fails, what do I do? How do I train my team when the red light goes on or the screen starts flashing? Instead of just ignoring that and moving on, is what do I do when there are exceptions? This is where I see a lot of healthcare organizations kind of failing. We stick to the 80 or 90% and we forget to train our team about what to do with the 10% that aren't working. They can't go through because you and I both know they're going to create a denial on the back end. So solve for it and train our team on how to do such. Adam?
Amazing. Dr. Woodcock, that's all the time we have left. If you wouldn't mind throwing that thank you slide up so folks can know how to contact us. But thank you so much, Dr. Woodcock. It's always a pleasure to be with you on the webinars. I want to sincerely thank you for your engaging presentation. Folks, again, if you have questions for Elizabeth, and for us, you can reach out. We'll make sure they get through. And again, if you want to learn more about Phreesia, you can request a consultation using the form on the right-hand side of your screen. Thanks again for joining us. Thank you so much, Elizabeth.
Thank you.